Good afternoon. Thank you. This is a big honor for me to be here, and I thank you for the invite this afternoon. Unfortunately, I'm going to present my talk in English. But as I move along, I'm hoping that what I'm going to present to you actually is something which, even though it's in English, will be clear. I am clearly thrilled to hear the previous speakers, and some of what I'm going to talk about already has been mentioned, so that's going to be a reinforcement of what you've heard before. But clearly I feel like I'm amongst friends, and I know some of you for quite a while. And again, I think that what we're trying to do is not change in the whole world, but just change a small amount of the world in terms of improving what we do on a daily basis. You saw that from the type of surgery we do, some of the approach to transfusion, some of what you hear from our colleagues in anesthesia in terms of preparing patients. Which is a concentration, but we use hemoglobin level as if it's a static number, and then talk about oxygen and oxygen delivery, and can we combine the three in terms of looking at patients where we treat life-threatening anemia. I'll go a little bit about what we have as far as the protocol with bloodless patients, talk a little bit about outcome, but the outcome has to do with all patients, not just bloodless patients, and then of course, a little bit of what I think is going to be next. If there is one thing that I'd like to straighten out and for people to walk away from the talks today, we treat patients for whom blood is not an option. Not patients who refuse blood, because there's a bigger population than those patients who want to accept blood. In many ways, though, keep in mind that most of us, meaning the doctors and hospitals, are the ones who have been refusing to treat these patients. So I think that we need to straighten the language a little bit as we go along. I was told that I have 80 minutes to talk. I think that's torture, so I'm going to make it a little shorter so that you don't get tortured. However, keep in mind, every time we talk about blood in medicine, it becomes emotional. There's very little science to this, but the emotion clearly prevails. Those of you who are interested, and I don't know if this has been translated into Spanish, this is a book that was written by Doug Starr, who's an investigational reporter. And you can see the back of the book says, the sweeping story of a substance that has been feared, revered, mythologized, and used in magic and medicine from the earliest time. A substance that has become the center of a huge, secretive, and often dangerous worldwide commerce. Most of us in healthcare are unaware of the commercial side of blood, but it is enormous. And if you think that it doesn't affect the way we actually deliver blood to hospitals, the way we work with it, I think we need to re-examine that. But I take you back to the 1970s and 1980s. And at that time, in the United States, blood was a product. But Tom Zuck, a renowned pathologist, recognized the liability that pathologists and blood bankers would have at the time of the HIV and hepatitis C epidemic, and went to Congress, the US government, and pleaded with them to change blood from a product, which is liability, to a service, which has no liability. And he actually used these two sentences to change what we have today in the United States. Blood is no longer a product, it's a service. Is that blood is unavoidably unsafe and blood is inherently dangerous. He didn't mean your blood, he meant the blood that's in the blood bank. Now over the time we've had two areas that we talked about. We talked about blood management, which is mostly donor management, again, something that we'll see constantly. And then there's the recipient part of it, which is transfusion. We have been completely obsessed with transfusion. Transfusion is a therapy. What is the disease? We need to ask what's the disease and then apply the correct therapy to that disease. When transfusion becomes center stage, we forget one thing. And what we're forgetting is that transfusion happens to be a resource, but patients are clearly the center, and that's where care occurs. So we need to first identify a disease and then pull the appropriate therapy in terms of where and what patients need. Now keep in mind that if I was here this afternoon talking to you about diabetes, and all I talk about insulin, you know that that's not right, because diabetes is a much bigger disease, if you will, and has many applications in terms of therapeutic intervention. Just like anemia, which is the condition or disease, we can argue back and forth about that, but it really doesn't matter, that we treat. So transfusion is, you will see, a default. I'm going to take you back to when we started working with patients for whom blood is not an option. And what it is it was named bloodless medicine and surgery, but that's a misnomer. What it was is, again, by definition, we improved patients' outcome with the use of clinical strategies for the medical and surgical care without the use of allogeneic blood products, meaning without using bank blood. This happened to be, as you already heard, a multidisciplinary approach. Now, we used a lot of different clinical strategies. The use of other treatments before blood, such as erythroid-stimulating agents, on or off label. Again, it's what the patients need, it's not what the label is. Including nutritional supplements, including iron, folic acid, B12. The use of blood products in patients that were accepting blood would be the last resort. But you know that many other organizations, at least in the United States, and I know also in the EU, have what's called a package insert for any drug. When you open the box, there's this long piece of paper with very small print that you can't read, because if you did, you wouldn't take the medicine. In fact, blood has the same thing. And this is the circular of information that comes from American Association of Blood Bank, American Blood Centers, American Red Cross, and ultimately the FDA. And you could see that even they are practicing maybe not bloodless, but certainly patient blood management, because what they say is red cell containing components should not be used to treat anemia that can be corrected with specific medications such as iron, vitamin B12, folic acid, or erythropoietin. Whole blood and red cells should not be used as volume expanders or to increase oncotic pressure of circulating blood. Ladies and gentlemen, this is a package insert. This is on label. How many of our colleagues follow the label? They don't. They completely ignore what's in the label. So who benefits? This is why I want to expand the population we're talking about. So we're all aware that patients for whom blood is not an option include Jehovah's Witnesses. We also know that patients who are alloimmune, those who have been repeatedly transfused over the years, may develop enough antibodies that we cannot match them to another unit of blood. They can also benefit from this. Keep in mind, when blood is not available, such as military operations with prolonged evacuation, as well as civilian injuries with prolonged evacuation. And lastly, we all remember the epidemics, but we know that another one can happen, is when blood is contaminated and becomes, again, a serious risk for patients. At that point, we're all in the same category of patients for whom blood may not be an option, especially if it's a virulent organism that causes significant mortality. So Jehovah's Witnesses that we take care of represent a significant challenge in the United States. As you can see, where trauma occurs, about 12 to as high as 17% of the blood is used. In cardiac surgery, where close to 20% of the U.S. blood supply is used. And again, we know that there was general refusal, if you will, by hospitals to take care of this population. But we took them on, if you will, as a community, as a challenge in 1994. We decided we were going to do this in an organized fashion. Now, if you're not going to give blood, I would submit to you that you need to understand blood even more critically than if you just use blood all the time. And we do know from studies that have been done that physicians who have a very, very clear understanding of blood and transfusion have the lowest transfusion rates, whereas those who have very little understanding have a very high transfusion rate. So as we took this on as a challenge, we decided to do this in a scientific way. And again, we learned a lot about patients' rights, because now this applied to other patients, not just patients for whom blood was not an option. And there are some legal precedents in the US and I know in the EU. But before we embarked on this, we were concerned that we were going to be doing essentially human experimentation. So we went at the time to Professor Kipnis, who was the chief consultant on medical ethics to the American Medical Association, and we posed the questions to him. He then wrote a treatise to us, suggesting that what we're doing was not only commendable, but clearly ethical. So this is how we started off embarking on this to create this, if you will, a science. Now, one of the things that we did, and already was alluded to, is to, again, advise the doctors taking care of the patients coming to the hospital of what they would and would not accept. And just keep in mind that there's a significant amount of acceptance of derivatives of blood, but not directly of blood, but you need to ask, and you need to ask it in such a way that is non-threatening, meaning, do you understand what it is and what it is that you reject or accept in terms of treatment. And you can see that there are different things here, such as erythropoietin, albumin, immune globulin, clotting factors, etc. And all of them are fairly highly acceptable, but each individual patient must make that decision. And we have that data from our institution, and you can see that other people, this is from Canada, have also done the same thing in terms of assessing those patients. But keep in mind that no blood does not mean no treatment. It means the same treatment, and it's very, very important. We've seen patients who have come to our hospital because another hospital would do only the wrong surgery for them because they wouldn't accept blood rather than doing the right procedure. So you have to start with identifying what the condition is, whether it be scoliosis, and then do the proper surgery. We'll manage everything else around that. But now with minimally invasive surgery, as you can see, it's going to be easier for us to manage. But when we first started, the minimally invasive surgery for scoliosis was not there. But we weren't going to do the wrong surgery just because the patient would not accept blood. I'm going to use a case as an example. This is a 50-year-old Jehovah's Witness woman presented with a large pelvic mass. It showed about 27 times 19 centimeter pelvic mass and a 6.5 centimeter mass involving the right kidney. It was invading into the right renal vein and inferior vena cava. So this was clearly very complex. Her medical history included anemia. As you could see, that a BMI, meaning she was very heavy, was 59, asthma, arthritis, sleep apnea, and high blood pressure. These are the medication. Her initial visit to the hospital, she had a hemoglobin of 9.9 and had a normal coagulation profile. She was enrolled into the bloodless medicine and surgery program. Preoperative counseling was performed. The patient did not accept any transfusion or any major fractions of blood as you'd anticipate. We obtained, again, a group of us. We had a hematology consult in terms of the anemia secondary to malignancy, which makes it a little more complex. The regimen started of ESA, oral iron, which again we don't use anymore, but keep in mind this is 2007, and folic acid. A week later, attempts of bilateral uterine artery embolization by interventional radiology. We were successful in the right uterine artery embolization. Her hemoglobin, you could see, continued to drop, and she now was given IV iron with ESA. One of the major failures of ESA therapy is actually not appropriate iron administration, and she was admitted to a hospital. Over the next 2 weeks, hemoglobin continued to drop because she was bleeding into her tumor. Again, you could see a group of us got together, and we decided on a two-stage surgical approach. First, to remove the pelvic mass, and then the renal tumor. The therapeutic paniculectomy to optimize surgical access given for morbid obesity, and again, there was potential blood loss from both. For preoperative evaluation, we included our intensive care unit anesthesia team, and again, we were preparing to make the intra and post-operative care as tight as we possibly could. Patient fully participated in all the pre-op discussion and consented to proceed with surgery without transfusion, despite now a hemoglobin down to 7.1 grams per deciliter. So we performed extensive surgery to remove a 35 centimeter uterine leiomyosarcoma adherent to the bowel. Adherent to the bowel, and again the vessels and retroperitoneal structures. Her intra-op hemoglobin dropped to 2.5 grams per deciliter with an estimated blood loss around 2.5 liters. Again, we gave her some recombinant factor 7 at the time because there was a consensus that she had some level of coagulopathy. Again, we had concentrated red cell blood collected and filtered through a leukocyte depleting filter and gave it back to her. And again, fluids were given, as you could see, both colloid and crystalloid, and she did accept albumin, but only a small amount. We don't really use a lot of albumin in our institution. No acute domovolemic hemodilution was performed because the starting hemoglobin was too low. You already got a glimpse. You could see this tumor, clearly bigger than my head, and we again were able to remove this. She was transferred to the intensive care unit with a plan to supportive care, limited blood draws, again using neonatal tubes, management of anemia, and parenteral nutrition. Iron and daily ESA continued, hemoglobin raised by about 1 gram per week. Post-operative complications, she had a DVT several weeks after surgery requiring low molecular weight heparin, but the DVT was in the upper extremity, most likely due to a central catheter. She eventually achieved a full recovery with no neurological or cardiovascular deficit, and she was discharged home. Now, again, just to demonstrate to you that these are extreme cases, but with coordinated care and understanding what needs to be done at every stage of the game, you can actually achieve success. And this is one example. I use that because, again, the hemoglobin was down to 2.5, and it was due to surgery, starting with low hemoglobin because we weren't successful in raising it. But the patient had every opportunity in full treatment. It's interesting that what we started to see after this is in 2006, is countries developed some protocols which were again distributed to physicians looking after and taking care of patients when blood was not an option. What about the other population? After 9/11, we were approached by the US military because they knew they were going to go into an area somewhere in the Middle East, we did not know it was Afghanistan, where it was high altitude and long distances to evacuate injured combatants. And in fact, what they did is they came to us and we met with all of the special forces. And within 24 hours, they essentially adopted the protocol that we had for patients in our hospital to the military. And that was done within 24 hours. And you could see again that they actually did use this protocol. They made it more military than ours. I'm not going to go in detail, but essentially using all of the things that we were using in terms of caring for these patients. So what happened is that over time we started looking at our practice, and we saw that the patients for whom blood was not an option were doing just as well, if not better, than some of the other patients. And in my department, somebody raised a hand one morning to say we have 2 standards of care. One for those who don't take blood and ones who do take blood. We're still transfusing all the others at high levels. We should have the same standard of care applied to all, which we, again, did immediately. Which brings us to this principle of patient blood management. The definition of patient blood management, this is from the Society for the Advancement of Blood Management. This is the URL, is the timely application. Now what we're doing is we're planning. So it's the timely application of evidence-based medical and surgical concepts designed to manage anemia. Now it's no longer transfusion, we're dealing with a condition. Optimizing hemostasis, another condition, and minimizing blood loss in order to improve patient outcome. A multimodality, multi-professional approach, not blood product focus. What has happened over the last decade in the US is that the blood industry is contracting, and they recognize now that they need to also have some input into patient blood management. But if you look at their definition, this is AABB definition of PBM, is the appropriate provision and use of blood, its component and derivatives, and strategies to reduce or avoid the need for blood transfusion with the ultimate goal of improving patient outcome. Well, that's a great goal, but if you could see, this is completely product-centered. Not a word about what we're treating, just the treatment. You're familiar with probably with the 3 pillars here. Again, the looking at the condition, meaning the anemia,
minimizing blood loss, and by the way, we think of blood loss as being surgical. Let me just say that most blood that we lose happens to be from tests that we repeat daily on patients for no good reason. And then lastly, is what I'm going to be talking about is harnessing some of the physiology of anemia, and understanding the disease allows you to better treat the disease. We know that this disease or condition, anemia, is much more complex than just low hemoglobin. In the US, we divided this into a 4-leaf clover. You could see again coagulation, blood conservation, management of anemia. We added patient-centered decision-making, meaning that bring the patient in. They don't have to be patients from blood, is not an option. But anytime there's an issue of transfusion versus other therapy, and one doctor says transfuse, the other one says do not, we bring the patient to help make that decision. What I want to do is, again, show you that if we can't demonstrate improved patient outcome, this is not going to be worthwhile. And what I'm going to do is now address with you this issue of anemia, because I think it's very important for us to do that. And Professor Munoz already addressed some of it, but I'm going to look at it more from a physiologic basis. There's been a long tradition of accepting anemia as a harmless problem that can be easily corrected with transfusion. We do that. Many of us don't even know what anemia is. We don't know the definition. For the medical community, transfusion as a treatment for anemia remains a default position. You come into the hospital, you develop anemia. If you get to the critical point that the physician decides, you get transfused. You're not offered anything else, generally speaking. Already spoken and said by Professor Munoz, the new paradigm is anemia as an independent risk of morbidity and mortality regardless of the low hemoglobin or the underlying comorbidity. Only small decrements of hemoglobin can put you at risk. Now, we ignore that usually, but for the surgical patients, that small decrement in hemoglobin may mean a transfusion versus no transfusion. Because if you're going for complex surgery and you start with normal, say 13 grams per deciliter, and you lose 6 grams, you're going to be around 7. But if you're starting with 10 and you lose the same 6 grams, you'll be at 4. You know the difference in terms of exposure. Who's at risk for blood transfusion? Now, some of you have heard that blood saves lives. I tell our trauma surgeons that if blood saves lives, we don't need you. Just give the blood. We'll be okay. In fact, there are patients who receive lots of blood who don't survive. And how do we explain that? So blood is an important part of the armamentarium for resuscitation of hemorrhaging patients. There's no question about that. We can only identify that population, even though it's small, retrospectively. On the other side of the scope, over here, we know that a fatal hemolytic reaction can occur very quickly, and blood can kill. But again, it's a small population, and this population, by the way, can be identified prospectively, but not the individual patient. It is these patients that receive between 1 and 3 units of blood that make up the whole idea in terms of patient blood management. Because if you cannot demonstrate benefit of the transfusion, all you're offering the patient is risk. So I'm going to move on to defining anemia, effective anemia, impact of perfusion anemia, oxygen anemia, and hemoglobin anemia. Now the concept of anemia is one which we have been very narrowly looking at. There's something called DO2, for those of you who know. This is oxygen delivery, which is calculated. There's something called VO2, which is tissue oxygen utilization. The ultimate of the reason for delivery is for the tissues to be able to use oxygen, and as such, hard to measure. There's oxygen extraction, the difference between delivery and usage, if you will, and that varies from disease state to disease state. And then there are other concepts in anemia which we're blind to. Oxygen diffusion. Keep in mind, hemoglobin only delivers oxygen to the aqueous interface. If you have cells in the back row, like some of the people, you're not going to get the oxygen from hemoglobin. It's diffused. So now there's a pressure that has to be addressed here. Then there are genetic changes that occur and they occur immediately as the hemoglobin drops, especially into a critical position. There is red cell velocity, which is very important for unloading of oxygen. And of course, there's functional capillary density, which I'll show you the principles of, which we completely ignore. And lastly, the effect of viscosity on anemia, especially when it's significant. Manises and others in the early 90s recognized that there was something called hypoxic-inducing factor, which is again, you can see that in response to hypoxia and anemia, HIF-1 alpha and beta induces the expression of genes that influence angiogenesis and vasodilatation. They actually do a little more than that because they can change necrosis to apoptosis. So if you have a lesion occurring because of low perfusion and low oxygen delivery, those cells or those individuals who have high gene expression end up having very little damage, and those who have very low gene expression end up with a very high damage. Hence, the same patient with the same lesion, one of them has a big CPK from an MRI, and the other one has a small CPK from an MRI. This one is apoptotic, this one is necrotic. Now, there are medications that we're trying to develop to help stimulate this gene expression. Professor Munoz already addressed the fact that this should be retired. It's over 65 now, right? They can go to pension. It's an old definition from the WHO done on patient population distribution. And you can see here that arbitrarily for women, the cutoff was at 12 grams per deciliter or below meant that they were anemic. And for males, it was 13 grams per deciliter. There's a lot of argument because you could see here that some of the normal people still fall into the category, but yet they're defined as anemic. Here's another thing I would like all of you to walk out of here today understanding. Hemoglobin is a concentration. At the time these population studies were done, the red cell mass of women was considered to be lower than the red cell mass of men. Now that may not be the same case today, but we don't have the information. So the red cell mass, the number of red cells available to deliver oxygen is different. The concentration should be the same. So if you believe in equality, again, I would say that it's 13 grams per deciliter if you're going to use hemoglobin. But I will show you that there's a lot of controversy around that. And the question, of course, is how meaningful is hemoglobin alone in terms of determining the red cell mass? Because it's the red cell mass that's important, not necessarily the hemoglobin concentration. Just to show you that there's argument, these are different publications with different definitions of anemia, but it really doesn't matter. They all revolve around the same number. But you can have a hemoglobin of 13, which can go down to 11 if you're very hypervolemic. Or you can have a concentration of the hemoglobin go up to, say, 16 or 15 and a half if you're hypovolemic. And the fact of the matter is, your red cell mass hasn't changed at all. So post-operatively, what we see in a lot of patients is a reduction in hemoglobin concentration, which is mostly fluid coming back to the circulation rather than decrement of red cell mass. But we don't have a non-invasive way of measuring red cell mass.
Again, this is one publication from 12. Hematocrit, or hemoglobin, is invalid for estimating red cell volume in a prospective study in male volunteers. Only red cell volume shows sufficient stable intra and inter-individual values to be accurate, an objective indicator of normality in blood composition.
But we don't have a way of measuring it well, so we resort to hemoglobin. Are there any other ways of defining anemia? Well, yes, there are. We could look at tissue hypoxia, hypoxic cell response, again, as compared to optimal hemoglobin concentration or normal red cell mass. There are biomarkers, NOs, there's methemoglobin, all have failed in terms of predictability of red cell mass and its increment. Some have suggested that we define anemia when we decide to treat a patient. That's not worked out either. So you can see that all of this stuff that we do, it still leaves us with, unfortunately, a measure which is insufficient, but yet we treat patients on a very insufficient measure. What anemia does, or as you decrease your red cell mass, your total body extraction of oxygen now from what's there increases, and it's almost linear. You could see as your DO2 or hemoglobin is reduced, your extraction of oxygen from red cells increases. But the extraction is only, again, total body. We really need to understand the extraction in different organs. Now, this is total body. As you can see, this is, again, the amount of extraction is very small total body. We can increase it with anemia, but it's still normally relatively small. The heart extracts a lot of oxygen, but still has reserve. The brain extracts a little more than the total body, but again has a lot of reserve. The gut has enormous amount of reserve, and then the kidney also has enormous amount of reserve. But we need one other thing we need to understand, and that is the sensitivity of these organs to reduction in red cell mass and oxygen delivery. And we have been taught that the organs that are the most sensitive include the heart and the brain. But in fact, when you look at this, both of these are insensitive to reduction of red cell mass, or as reflected by hemoglobin, compared to the kidneys and compared to the muscle. So again, misleading information, and we don't really do that because we have relied on something very, very different. We have relied for years on calculations, on formulas. And the formula that most of you are familiar is the carrying capacity of oxygen. And the one that's most weighted is hemoglobin level. The hemoglobin level goes up and down. Your capacity to carry oxygen is reduced significantly one way or the other. We've also ignored dissolved oxygen. But keep in mind, these are calculations. When we start looking at measurements, and I'm going to skip this slide because I don't know how it came in there. When we start doing measurements, we find different things than actually the calculation. But before I move there, I think we have to understand the relationship between delivery and oxygenization. As your delivery goes down, the red cell mass goes down, so does the amount of oxygen content in the blood. There's no question about that. Until you reach what's called a critical number. That critical number in human beings is thought to be between 4 and probably 4.5 to 5 grams per deciliter. It varies from individual to individual. I showed you a patient who had a hemoglobin of 2.5 who survived and went home. So it does have some limitations, but it's a pretty good number to use in the back of your head. The issue was that if you become supply dependent, and keep in mind, meaning that you don't meet your needs, when I was trained, I was told that if you go down this slope, you don't come back. We know today that yes, if you get that early on, the opportunity, and reduce the time you spend in supply dependency, you will come back. Now, there is a big difference between a calculation and measurements. So now what we do is we calculate hemoglobin, and we ignore the saturation of hemoglobin, dissolved hemoglobin in the plasma, and we say that if carrying capacity is reduced, give blood or hemoglobin, and everything is going to be okay. But when we measure that, do we get the same response? This is data from San Diego, from the laboratory. There's other data also from Austria and Germany. And it shows you the different decrements. This is 60% reduction of hemoglobin from 15 down to 6, 50%, 30%, and 20%. This is your DO2 at baseline. And this is the number of units being transfused. And as you could see, when you transfuse units of blood, lo and behold, the opposite happens. And I think that Professor Manises alluded to that before. When we start doing measurements, the calculations are out the door. It is only in this particular population where hemoglobin is 60% reduced that DO2 actually goes up, but only by 4%. Nothing tremendous by any means. And there are clinical studies looking at oxygen extraction and transfusion. Again, it was not statistically significant. This is another study that RBC, this is in sick patients where we think we may be able to help them. RBC transfusion not associated with improvement in tissue oxygenation in patients with systemic inflammatory response and sepsis at hemoglobin levels less than 9 grams per deciliter. So we're not helping these patients. This is the same data looking inversely, so I'm not going to spend time. But what about when we resuscitate the patient to keep their blood pressure up and they have low hemoglobins? You could see that when you give dextran, which is high viscosity, versus lactate, which is low viscosity, after 1 hour, oxygen tension, which is measured, by the way, reduces significantly with crystalloid versus high viscosity fluid. So we do make a big change by the type of fluid that we choose an intervention. And here's data from Amy Tsai, also again, this is from San Diego, looking at 13 or 14 grams of hemoglobin, hemodiluted down to 5.5 or close to that, with high viscosity fluid, and measuring oxygen tension. You can see that at every place you go, you can sustain oxygen tension. You may even increase it, but it's not statistically significant with high viscosity fluid. And experiments that we have in humans, this is in volunteers, you can see that they start with a hemoglobin of 13 down to 5 grams per deciliter. Cardiac index, as you'd expect, went up. Heart rate went up. Only one patient had tachycardia up to 92. Systemic vascular resistance dropped, as you would expect, but oxygen utilization, not delivered, actually improved. It wasn't statistically significant, but certainly was not worse. And lactate, there was no difference. So again, we need to understand whether the damage occurs or whether there's compensation. And how do we make the organs compensate so that they don't get damaged in patients, again, for blood is not an option, and make sure that they stay in a supply dependency for a very short period of time. Which brings me to the microcirculation. We do all of our tests and all of our thinking in the microcirculation, but again, where the business of life, if you will, occurs is in the microcirculation. And there is a circulatory response which is very different in the macro versus the microcirculation, including generation of energy. This is a schema, if you will, or a diagram showing you macrocirculation when there's plasma and red cells. They're there together and they move fast and they move very nicely. But when you get down to the capillaries, what happens is everything changes. The amount of plasma per red cell is again increased, meaning there's more plasma per red cell per unit of time, defining that as a low hemoglobin concentration. All of you have anemia, if you will, in your microcirculation right now. It works for you. And at the point where that gets critical is usually around that 4 to 5 grams per deciliter, but keep in mind it's individual. But notice, not every capillary has red cells in it. Some just have plasma. If you recall from what I told you before, we throw away the dissolved oxygen in plasma. Ladies and gentlemen, I tell you right now, the only way oxygen gets here is through dissolution in plasma. And if we can increase it, and as your red cell mass goes down, your contribution from plasma can be as high as 35%. Now this is called functional capillary density. You want to have all the capillaries perfused, with red cells and without. But sometimes we drop capillaries. And this is the difference between volunteers and patients with sepsis, where functional capillary is reduced. Functional capillary is very important for survival. This is a video, some of you may have probably seen this. Let me see if I could start this. This is a video of capillaries in a human that has a hemoglobin of 3.8, but you could see that every capillary is filled. The functional capillary density is high. It's all perfused. Perfusion is more important than anything else, because if you don't perfuse an organ, there will be no oxygen delivered. If you perfuse the organs, but your hemoglobin or your red cell mass is low, you will still bring oxygen, but you may not meet the needs. Remember the supply dependency. So at 3.8 grams per deciliter, what do you think happens? Patients get transfused, and this is after a single unit of blood that this patient receives. I want to show you the capillary. So now you see what happens. The blood that comes from the blood bank is not the same that's in the patient's veins, and you can see that there are areas where there's plasma, clumping of red cells, slow movement, again, areas where there's swelling. The capillary density has gone down, and it's gone down significantly. And we do know from data out there that functional capillary density has an impact, again, on survival in patients. You can see that as your capillary density remains as, again, a function of time, you have a higher survival than those patients who have a lower functional capillary. So here we are talking about hypovolemia, anemia, and hypoxia, and oxygen delivery. And to manage anemia, whether it's severe anemia with or without blood, you need to have perfusion, excuse me, you need to have oxygen delivery, and you need to have a sufficient, excuse me, red cell mass. Now, in a surgical arena, what we try to do is we try to get the patients to go to this journey with a full tank of red cells. However, we don't always give them the opportunity. Every one of you in your life monitors what you do. I'll show you in a minute why I say that. But when it comes to hospitalized patients, we take something in the beginning, and then we wait for something to happen, and then we get another look, if you will, at them, missing an enormous opportunity. So when you're going from València to Madrid, you want to start with a full tank in your car, right? And lo and behold, you start with a full tank, but you don't not look at your tank as you're driving. You're always looking at things in your car because you have continuous measurements. And you don't want to wait till you get to here to stop to get gasoline or diesel, because you may not find a gas station on the road, and you may not have, again, the opportunity to fill. And keep in mind, 14 versus 7 grams per deciliter is pretty similar. Now, what happens to us in the hospitalized patients is we measure this, and then we measure this, and then we go, oh my God, it's so low. We got to go hell and immediately start replenishing that. And what do we choose? We choose either red cells, sometimes platelets, sometimes plasma. These are the international color codes for those individual resources. Notice it is a response to something which we lost an opportunity. This is not a scientific way of dealing with the patient, because I already mentioned to you that this is a default position. So if we have a situation like this, and we're looking at the beginning, is there a possibility for us to look for the opportunity, which again, as you could see, that opportunity lies in this range, not in this range. We've lost the opportunity, and so has the patient, because our response always is going to be one of these. Now, I also mentioned to you that blood loss comes from not necessarily surgery, because a lot of blood loss comes from the fact that we need to get one of these filled to do a test and get the results. And again, Marcel Levy shows here that 25 million liters of patient blood is thrown in the waste containers every year, 4 times what we transfuse patients annually. So again, this is a serious problem. And we know that we take a lot of blood from patients. Those of us who are healthy can make possibly 40 ml a day. If you're sick, you may not be able to make half of that. And some of you who get really sick, or us who get really sick, may not be able to make any. But we keep taking blood away from patients. And what do we blame? This. We blame these tubes. Nice colors, different sizes. The fact of the matter is somebody has to fill them. And it's us who are ordering those bloods. And that's where we get into trouble. So just like the gas tank is their ability for us to monitor patients without taking so much blood from them. And this is commercially available. Here's your concentration of hemoglobin measured non-invasively. Here is your volume reflection, which is pleth variability index. And here's your perfusion index, which I will address with you as we go along. But we're missing one arm, and that is the oxygen arm. And now that also is available commercially here in Europe, not in the United States, but we're looking at this experimentally now at a non-invasive way of looking at reflection of PO2. We can only do saturation, we cannot do PO2. Keep in mind again, calculation versus measurements. And here again, I remind you that the dissolved oxygen is very, very important for us. And we can actually make sure that the dissolved oxygen maintains high if we give patients who have critical hemoglobin levels or critical anemia enough oxygen to sustain a PO2 above 200. And lo and behold, this is something you're probably all familiar with. Saturation at 100%, PO2 in normal individual at 1 atmospheric pressure is a little greater than 600. Until you could see that your PO2 can drop significantly until it affects saturation. We are missing an enormous opportunity here to reverse things for patients if we don't have a window into what is going on, unless we draw blood. And we don't know when to do that. But with a non-invasive way of measuring this index, you can see that from 200 down to 100, it's relatively sensitive in terms of depicting what is happening and early on. Here's a study that was done looking at this oxygen reserve index. Again, a significant number of samples. And the sensitivity is exactly where we want it, around the 200 range. Here's an example of a patient. This is saturation. This is the oxygen reserve index, more like a PO2. And you can see that the PO2, or the oxygen reflected by ORI, starts dropping before you have any significant change in your saturation. So it allows us to maintain, if you will, that dissolved oxygen much quicker to understand that it's changing than waiting till supply dependency. This is another study that was done in children, the pediatric population, during intubation, and you can see again, ORI clearly has an advantage in terms of time in alerting us before the saturation starts dropping. So there's your oxygen delivery in a non-invasive fashion. Now what about the other two elements, perfusion? We talked about the functional capillary density. The only way we could measure volume was through CVP, which, as you could see, has a very poor R-square. It's completely insensitive and very non-specific. But other measures that we've had, which include pleth variability index, stroke volume variability, as well as electrical impedance, have a much higher reliability in terms of determining whether the patient is fluid responsive, which is maybe a reflection of your volume state. In my institution, again, to be balanced, we use all of these. And I don't care which one you use as long as you use one of them, because it's important when you're managing patients who have blood loss during surgery to know where you are in terms of volume, because the concentration, as we already talked about, of hemoglobin can be affected significantly. So this one again uses stroke volume variability. This is used electrical impedance, and PVI, or pleth variability index, is used with that instrument. So you're tying together now pleth variability index, the perfusion index, the hemoglobin, and in the US we don't have what you have here, which is the oxygen reserve index. Now, a lot of physicians have gone by and said, you know, this is insensitive, you shouldn't be using it, it's not accurate. Well, we responded, my colleagues and I wrote this article responding to all these criticisms. If you're flying a plane and you have two altimeters, you know, the height level of where the plane is flying, and you're flying at 10,000 meters, one monitor you have is down to 1 millimeter difference. It is very, very accurate. The other one is about 2 meters, plus or minus. The one that gives you the 1 millimeter, you can only see every 6 hours. And the other one with 2 meters is on all the time. You want to fly the plane, which one will you choose? Clearly the one that has less accuracy, but has continuous sensitivity and the ability to continuously monitor where you are. So we need to learn that. This is again looking at the two together. This is PVI, and you can see that as the volume of the patient's ability to accept volume, which may be a reflection of the volume state, as pleth variability index goes up, they get fluid and it goes back down to normal. It's inversely related. Here's again a patient who has changes in their volume state, receiving all sorts of, again, fluid challenges. But over here what they did is they did passive legs raising, and when the fluid came back from the legs, you could see the concentration of hemoglobin goes down. You don't have the rest of the slide here, but it goes back up to normal. So once the legs go down. So again, the concentration of hemoglobin may change, but not necessarily the red cell mass. Here's another way we could look at this. This is a patient who gets transfused, again, with multiple units. There is no reason to give this patient more unit once they reach, say, hemoglobin of 9 or 10, but they keep transfusing the patient because they're waiting for laboratories to come back. Here again, a similar situation, but now you could see that the concentration of the fluid goes down, and the concentration of SpHb, or the hemoglobin, also goes down with it, suggesting that there's a reduction in red cell mass. So it gives you both the concentration, if you will, as well as the fluid status here, and once you get patients receiving blood here, it goes back to normal. Again, another case where 2 may be enough. This is a GI bleeder where you could see where you're starting from with the hemoglobin. They get 2 units of blood and they reach about a hemoglobin of 9 to 10 grams per deciliter. But they keep giving more blood, 3 and 4, 5 and 6. No benefit at that point, only risk to the patient. And here's a patient in our intensive care unit that came in with a hemoglobin, as you could see, around 6 grams per deciliter. She had pneumonia. Everything else was stable, including her PO2. She was started on erythroid stimulating agent and IV iron, and you could see that now we could follow her hemoglobin continuously, giving confidence to the physicians. She did not receive a drop of bank blood and did well and got discharged. I want to share with you some of our data. 8% of all our population of patients admitted are bloodless compared to, again, non-bloodless patients. Of the non-bloodless patients, around 81% don't get transfused, and this number, actually close to 20%, is now even further down to around 10%. So we have protocols that we've devised. You could see, again, significant mortality. We use high-dose EPO and IV iron. We use the physiology and the pharmacology of the drug rather than the label. Again, you could see we use different preparations today of iron. We just had Maltos approved. Again, minimizing blood draws and consider using something called hemoglobin-based oxygen carriers. I'm not going to go through the detail, but again, we look at all 3 elements, the oxygen, the volume, and red cell mass. I'm not going to talk about cell recovery or ANH today, which we use. I want to show you a little bit data in terms of the different artificial bloods or hemoglobin-based oxygen carriers. There's hemoglobin-based oxygen carriers and there's perfluorocarbons. We're probably not going to see these anymore. And we looked at experience with 54 patients who had life-threatening anemia, who accepted and received this on compassionate use. And then we had a patient that we kept, again, alive, who went home after chemotherapy, was maintained on this for 3 weeks. This is a complex drug, not a blood, it's a complex drug, and again needs knowledge on how to use this. So again, just looking at this, this issue with the trial. We published, in comparison to Carson, who published his data in 2002, our data was published in 2014, looking at, again, the difference in terms of survival in hemoglobins. To our surprise, when we looked at the data, you could see that we did better for any of the hemoglobin levels except for this particular range here. But this is because patients were dying from other reasons. But we did better, but it was not statistically significant. And we could not understand why, with all of what we were doing, that we weren't able to show a statistically significant difference between what was done in 2002, which was nothing, versus our aggressive therapy for patients. And if you recall what I mentioned to you before, if you spend a lot of time over here, your mortality clearly is going to be higher than if you spend very little time here with a very low red cell mass. And lo and behold, when we examine our data, we could see that most of the patients who increased our mortality rates had been patients who were transferred from other hospitals where no blood meant no treatment, and they were in a very dependent state, meaning oxygen dependent state, for quite a long time, which again was associated with a higher mortality. There are other experiments out there looking at different other molecules. This is sanguinate, and again, works very well. But again, none of these are FDA approved. You can only get them for compassionate use. But I think it's important to have that armamentarium here too. I'm not going to go and talk about HBO, which is hyperbaric oxygen therapy. I'm not really sure that it has a place because you can't sustain the dissolved oxygen well, and it causes vasoconstriction, which reduces your functional capillary density. We have not had good experience with that. Here again is a combination of a patient with a combination of EPO and acellular hemoglobin. You could see again, you're using you can measure your free hemoglobin in the plasma. This is the drug, and you can correlate when you need to give more of that to the patient. Again, this is another young individual where they had free hemoglobin due to the HBOC, or the hemoglobin-based oxygen carrier, and you could see that over time their hematocrit improved, and they did fine with the drug. We have a management of anemia, which includes, again, for those patients for whom blood is not an option, based unfortunately still on hemoglobin level, but again, this is just a guide, and the guide is a very aggressive treatment. When we looked at the population of patients, we just got accepted for publication, and it's now close to 300 patients, almost double that. You could see that there's no difference in terms of the Apache score or the SOFA scores we see in Europe. And what we did is we matched them as if these were going to be transfused versus these who are transfused. Mortality rate was not significantly different, although it was slightly higher in the bloodless patients. Positive cardiac enzymes was significant statistically and much higher in the transfused patients versus none, and after showing you the capillaries, you may understand why that may be. And this is the depiction of mortality, and now keep in mind, yellow is transfused, red is non-transfused, meaning on protocol. Now it's very hard to find transfused patients who have this low hemoglobin of 2. We were able to find 1, but most of them get transfused clearly at this range, or maybe even higher. But you could see that at high hemoglobin, the non-transfused do better than the low hemoglobin rates. However, in Carson's paper, patients who had a hemoglobin that was below the 2 grams per deciliter, mortality was 100%. So you can see now the difference is somewhere around 55%, and I submit to you, more of us doing this, we're going to get better and reduce mortality. Already, my colleagues already presented some of this data, but in the US we have something called the National Blood Collection and Utilization Survey Report, which is basically blood-centered, but in 2011, the first chapter came out about patient blood management. And what's interesting is that you can see how many facilities responded that they had patient blood management. And again, one of the things that we saw also is that the established program to treat patients who refused transfusion, is the way to define it, went from 15% to 57%. I think that's a big advance in terms of us not refusing to treat patients. Looking at educational programs, clearly they're much better in patient blood management hospitals. However, we still use transfusion guidelines. And I just want to make the point. The transfusion guidelines, you could see 84 to 98% of them are derived from the blood industry. This is a trade organization. American College of Pathologists may or may not be considered one. Again, American Red Cross is another trade organization. If Eli Lilly was standing here giving you guidelines on antibiotics, you'd probably laugh them out of the room, right? But this sounds like it's scientific.
In fact, it's not. Now, it may not be biased, but I just want to make the point that our
Guidelines for this particular therapy come from the industry. We're seeing a change in evaluating patients for surgery, and we're also seeing a change in use of other parental combinations. This one, I was very surprised to see that the use of IV iron in preoperative preparation of patients has increased dramatically in the US. As again, you can see we still have work to do in terms of restrictions and other modalities that need to be done. So this is now becoming a patient safety issue, both in the US and in Europe. This is the National Patient Safety Foundation in the United States, which is now focusing on patient blood management, and we hope that they look at it from the patient and not from the product. We are now, this is an example, please don't call any of these doctors, but we are now looking and tracking behavior by a physician. And this data is done on a monthly basis and collated and given to the chair of each department. And they look at this in terms of complications, infection, and mortality. Again, here you've had advances. This is patient blood management is a win-win, a wake-up call. And now you know that there's the European Patient Blood Management Project, which has started, where there's funding from the EU on that. And there's now also guidelines based on the Australian guidelines for patient blood management. And there is clearly more to come once we start seeing some of this information. But make no mistake, this country clearly is a leader, I'll show you some of what comes out of here. This is from Maine, showing again a significant reduction in transfusion rate with reduction in AKI without having any other effect. This one comes from our friends at Hopkins, looking at protocol versus non-protocol, and I think this speaks very loud. These are protocol patients, look at in-hospital mortality, this is versus transfused, and these are stratified, length of stay, infection, thrombotic events, no difference over here, any morbid outcome or death, again, favoring the protocol patients versus non-protocol patients. And this is our data, it's a little old, but looking at cardiac surgery, and you can see that we use all of the pillars in terms of how we approached our patients, and then we compared ourselves to all of the other hospitals in our state in terms of in terms of patient blood management versus non-patient blood management. And here's our hospital transfusion rate is 10.6 versus 42, mortality 1/3, and again, serious complication close to half. Important to understand, patient outcome has to be demonstrated. Now, you know data is power, and we're always waiting for randomized controlled trials. Randomized controlled trials are not data. Very different. They usually ask one question, and we've been asking this question forever and don't get an answer. We're looking for the number to transfuse patients. It's a wrong question because for all the years we've been asking it, we've not gotten a good answer. And we still spend a lot of money doing these studies. Let me show you where data is going to come from. These are two hospitals, again, looking at patient blood management initiative and total knee replacement patients in the first half of 2011. And again, you can see that the data can be actually collected very easily. This is a patient blood management hospital, and when they started, this is a non-patient blood management hospital. Here again, you can see transfusion rates have significantly dropped in the patient blood management hospital at these quarters compared to the non-patient blood management hospitals. And lo and behold, when you see here that hospital-acquired anemia, respiratory complication, cardiovascular complication, post-procedure complication were significantly reduced in the hospital that has patient blood management compared to these. This is ongoing clinical data that's stratified. It is much, much more powerful than anything else that we've seen through randomized controlled trials. And for those in the audience who are hospital administrators, you probably want to look at this. This is the patient blood management hospital. This is the one that continues to do things the same way. This is the benchmark for doing this particular knee replacement. And take a look at the margin that the patient blood management give. Not only in terms of outcome of patient's clinical outcome, but we also have significant reduction in resources. This is not something that's new to the people sitting here in the audience. And I'd like to quote the author saying that the benefits of patient blood management programs, both for the patient and the health care system, appears indisputable. But they are not easy to implement as several obstacles need to be overcome. I think the biggest obstacle that has to overcome is us. Again, once we overcome us as the obstacle, I think it's be a lot easier. So with that, I thank you.